Welcome to our cystic fibrosis review for USMLE Step 2. In this video, we will master the pathophysiology of the CFTR defect, the multi-organ clinical manifestations, diagnosis with newborn screening and sweat testing, and the modern era of CFTR modulator therapy. Let's get started. Cystic fibrosis is an autosomal recessive disorder caused by mutations in the CFTR gene on the long arm of chromosome 7. It is the second most common genetic metabolic disorder in individuals of Northern European descent. Key points to know. The most common mutation is delta F508, also called F508del. CFTR normally functions as an ATP-gated chloride channel on the surface of epithelial cells throughout the body. When defective, chloride transport fails and secretions become thick and viscous. If both parents are carriers, each child has a 25% chance of being affected. Step 2 Pearl. The misfolded CFTR protein is degraded in the endoplasmic reticulum and never reaches the cell surface. This is exactly the defect targeted by modern CFTR modulator drugs, which we will cover shortly. The respiratory manifestations of CF dominate the clinical picture and determine prognosis. Patients develop chronic obstructive lung disease with bronchiectasis, meaning irreversible dilation of the airways. There are recurrent productive cough episodes and chronic pulmonary infections. Chronic sinusitis is common, often with nasal polyps. Physical exam shows moist rolls on auscultation, dyspnea, and sometimes hemoptysis. Digital clubbing develops from chronic hypoxia. Step 2 Pearl. Bronchiectasis in a young patient should always raise suspicion for cystic fibrosis. Progressive respiratory failure is the main cause of death in CF, which is why airway management is central to treatment. The bacterial pathogens in CF change with age, and this is high yield for Step 2. In infancy and childhood, the most common cause of recurrent pulmonary infection is Staphylococcus aureus, followed by H. influenzae and S. pneumoniae. In adulthood, the most common pathogen becomes Pseudomonas aeruginosa. Other important adult pathogens include Burkholderia cepucha and Stenotrophomonas multifida. Burkholderia cepucha deserves special mention because it can cause Cepucha syndrome, a severe necrotizing pneumonia with rapid clinical decline. Step 2 Pearl. The progression from Staph aureus in childhood to Pseudomonas in adulthood is a hallmark of CF and predicts declining lung function. Pseudomonas is very difficult to eradicate and requires aggressive treatment. The gastrointestinal manifestations of CF affect nearly every part of the digestive tract. Meconium ileus in newborns is failure to pass meconium in the first 24 to 48 hours, presenting with bilious vomiting and abdominal distension. Almost 100% of newborns with meconium ileus have CF. Pancreatic insufficiency causes steatorrhea, malabsorption, failure to thrive, and deficiency of fat-soluble vitamins A, D, E, and K. CF-related diabetes develops as pancreatic destruction progresses, typically in adolescence or adulthood. Other complications include rectal prolapse, biliary cirrhosis, and distal intestinal obstruction syndrome. Step 2 Pearl. A newborn who fails to pass meconium in the first 2 days is CF until proven otherwise. Confirm with the sweat chloride test. Beyond the lungs and gut, CF affects sweat glands and reproduction. In sweat glands, chloride and sodium cannot be reabsorbed from sweat, producing the classic salty-tasting sweat that parents often notice when kissing their infant. This can lead to hyponatremic dehydration in hot weather. This defect is the basis of the sweat chloride test. In the reproductive system, over 98% of men with CF are infertile due to congenital bilateral absence of the vas deferens. Spermatogenesis is usually intact, so obstructive azoospermia is the mechanism, and sperm can sometimes be retrieved surgically for IVF. Women have reduced but not absent fertility due to thick cervical mucus. Step 2 Pearl. A young man with infertility plus recurrent lung infection should make you think CF. Check for absent vas deferens on physical exam and order a sweat chloride test. The diagnosis of CF starts with newborn screening, which is mandatory in the United States and many other countries. The initial screening test uses immunoreactive trypsinogen, or IRT, from a heel prick blood spot in the first 24 to 48 hours of life. An elevated IRT level suggests possible CF and prompts further testing. The gold standard for diagnosis is the sweat chloride test, using quantitative pilocarpine iontophoresis. A sweat chloride level of 60 millimoles per liter or higher confirms the diagnosis. Values between 30 and 59 are intermediate and require genetic testing. Genetic testing confirms the specific CFTR mutation and, importantly, guides which CFTR modulator therapy the patient is eligible for. Step 2 Pearl. 2 positive sweat chloride tests on separate occasions confirm the diagnosis. Always follow a positive newborn screen with a sweat test. The main differential diagnosis for CF is primary ciliary dyskinesia, a rare autosomal recessive disorder caused by defects in the dynein arm of cilia. Cardiogenic syndrome is a subtype of primary ciliary dyskinesia. The classic cardiogenic triad consists of situs inversus with dextrocardia, chronic sinusitis, and bronchiectasis. Also present are male infertility due to defective sperm flagella, reduced female fertility with increased risk of ectopic pregnancy from defective fallopian tube cilia, and sometimes conductive hearing loss from chronic otitis. Step 2 Pearl. CF and cardiogenic both cause bronchiectasis, chronic sinusitis, and infertility. The key differentiators are situs inversus and a normal sweat chloride test, which point to cardiogenic rather than CF. Standard CF management focuses on preserving lung function and optimizing nutrition. For pulmonary care, the mainstay is airway clearance techniques, such as chest physiotherapy to mobilize mucus. Hypertonic saline nebulization improves mucociliary clearance through osmotic effects. Dornase alpha is a recombinant DNase that thins mucus by breaking down extracellular DNA in sputum. Short-acting beta agonists like albuterol act as bronchodilators. Inhaled antibiotics, such as tobramycin, are used for chronic Pseudomonas suppression. For nutrition, patients need a high-calorie diet, pancreatic enzyme replacement, fat-soluble vitamins A, D, E, and K, and extra sodium chloride intake. Prevention includes annual inactivated influenza vaccine and pneumococcal vaccination. Step 2 Pearl. Double lung transplantation is an option for end-stage lung disease. Single lung transplant is not performed in CF because the remaining native lung would infect the transplanted lung. CFTR modulators are a revolutionary class of drugs that target the underlying protein defect rather than just treating symptoms. They are chosen based on the patient's specific CFTR mutation, which is why genetic testing is essential. There are 2 mechanisms. Potentiators, like ivacaftor, work on the cell surface to open the chloride channel gate and improve chloride transport. Correctors, like lumacaftor, tezacaftor, and elexacaftor, help the misfolded protein fold properly, remain stable, and reach the cell surface. Combination therapy is the current standard. Trikafta, which combines elexacaftor, tezacaftor, and ivacaftor, is highly effective and now approved for the majority of CF patients, including most with the delta F508 mutation. Mnemonic to remember the drug names. Every modulator contains the letters CFTR somewhere in its name. Eva CFTR, Luma CFTR, Teza CFTR, and Alexa CFTR. Acute pulmonary exacerbations in CF require aggressive antibiotic therapy based on the sputum culture. For Staph aureus, if it is methicillin sensitive, use nafcillin or oxacillin. For methicillin-resistant Staph aureus, use vancomycin or linezolid. For Pseudomonas aeruginosa, always use double coverage, meaning 2 anti-pseudomonal antibiotics with different mechanisms of action. Typical combinations are an anti-pseudomonal beta-lactam, such as ceftazidime or meropenem, plus either a fluoroquinolone like ciprofloxacin or an aminoglycoside like tobramycin or amikacin. For resistant organisms like Burkholderia cepacia and Stenotrophomonas maltophilia, always consult infectious disease specialists. Step 2 Pearl. Always double cover Pseudomonas in CF exacerbations, and always obtain a sputum culture before starting empiric therapy to guide antibiotic selection. Let's wrap up. Genetics. CF is autosomal recessive, caused by mutations in the CFTR gene on chromosome 7. Delta F508 is the most common mutation. The defective chloride channel produces thick secretions throughout the body. Clinical features: recurrent pulmonary infections with bronchiectasis, chronic sinusitis, steatorrhea, and failure to thrive. salty sweat, and male infertility from absent vas deferens. Pathogens by age. Kids get Staph aureus. Adults get Pseudomonas aeruginosa. Burkholderia chepicha can cause Chepatia syndrome. Diagnosis. Newborn screening with IRT, confirmed by sweat chloride of 60 millimoles per liter or more. Genetic testing guides modulator therapy. Treatment. Airway clearance, hypertonic saline, Dornase alpha, pancreatic enzymes, and ADEK vitamins. CFTR modulators, especially Trikafta, are the modern standard. Double lung transplant is an option for end-stage disease. Finally, the classic step 2 traps. Meconium ileus equals CF. Always double cover Pseudomonas. Situs inversus with bronchiectasis is cardiogenic, not CF. And absent vas deferens is a classic finding in males with CF. Life expectancy is improving dramatically with CFTR modulators, now approaching 50 years or more. Good luck on your exam.